All right, so barriers to applying evidence to practice. So lack of time. Um, there's 6 challenges that were written by this group of Tashia, Bikuspy, Feely, and Leto. Okay, so there's institutional cultural barriers. So you might not work in a place that puts a lot of value on evidence-based practice. Lack of knowledge. So do they understand on how to search for it or how to use it? Lack of motivation. What if you don't get assigned time for that, right? Time management, obviously, physician and patient factors, and then limited access to up-to-date user-friendly technology and computer systems. Now, any facility worth a salt is going to start utilizing evidence-based practice, and they might not be able to reinforce developing a team to be able to do that, but at least getting access to it. Most places will. So nurses may also see the job of interpreting research as too complex or see the organizational culture as a barrier to their implementation. And a lot of people don't understand evidence-based practice and how to get it. So there are factors that will facilitate evidence-based practice. So driving forces are having knowledge and skill in evidence-based practice, which is why we teach it and reinforce it. Having a conviction that there is a value to using evidence and practices. Practicing in a supportive culture with tools available to sustain evidence-based care, including access to computers and databases, evidence-based content at the point of care, and the presence of evidence-based mentors. So, interprofessional collaboration and mentorship and administrative support is always necessary to adopt evidence-based practice. And it's really imperative that we remove these barriers and support nurses to use it, as well as mentor and work with those who are just beginning to initiate evidence-based into their practice. And if there's older nurses who weren't taught evidence-based practice, it's our job to make sure that they learn that. So it's not complex to implement a culture of evidence-based practice. So let's just stop a second here. So you read an article that states that the CAF is an appropriate alternative cuff site for non-invasive blood pressure measurement in pediatric patients. This is based on results of a single non-experimental study. According to Stetler, how should this evidence be classified? So a single non-experimental study. Would this be high quality, average quality, or lowest quality? All right, so hopefully you chose average to mid-level quality. And the rationale behind that is because highest quality is a meta-analysis. Average mid-level are usually non-experimental studies. And lowest quality is expert opinion. And still, wouldn't you want to use the higher qualities, right? Because to me, I'm like, that's not enough to know. So, oops, sorry. The collaborative component of research is supportive of informatics science. So technology is really important, and you want to make sure that you are using technology that supports clinical research and also provides a roadmap into initiative for medical and nursing research. So what's the role of informatics? So computers are used in all areas of research, right? The context for nursing informatics has expanded to support all these changes in the way science is accomplished. So information need and the collaborative component of interdisciplinary research is going to rely heavily on the use of technology and informatics. So social networking has also improved collaboration, and the use of technology and informatics in facilitating interdisciplinary and translational research is a key architectural component of the National Institute of Health, so the NIH engineering of clinical research enterprise. So we have to rely on each other within disciplines and other disciplines to promote translational research. So computers are used in all areas of research, right? Literature search with databases, online reference lists, data capturing, data analysis, data modeling, meta-analysis, qualitative and analysis, and then of course disseminating information. An example of the integration of informatics in the medical record, Matter describes the positive effect of a successful integration of referential links with evidence-based clinical components in the clinical pathway on patient outcomes. And you can get those links through your EMR. So technology continues to advance, and so will these tools that we use. And you want a rapidly evolving web tool developed by researchers in the translational domain, and that's something called REDCap, and it features a high degree of customizability to form and advance the user's right of control. So we're really growing in the way that we can use our evidence. So when we talk about informatics infrastructure, the infrastructure is critical to evidence-based practice. So although it's not specific to nursing informatics, the NIH provides awards for the transfer of research to the clinical setting. And for us in informatics, we talk about the QSEN competencies. And that is when we talk about quality and safety, there are these competencies that we have to understand when we talk about education and evidence. So developing evidence-based practice, there are lots of different models to use. I always use the Iowa model, so I will pull that up for you. There's many different ways. The Iowa model of practice, Iowa model of evidence-based practice. And I can actually show you oh no, I don't. So Iowa model of evidence-based practice is this really great model, and I want to show you a better, I'll show you an image of it. So it's an algorithm that you will follow, and here's some different articles on it. I actually think
Understanding the Iowa model. Start by identifying your clinical practice question. These questions are usually triggered through the identification of a problem in your setting or a new knowledge that you come across. Assess whether this topic is a priority for our organization, as a question aligned with our organization's priorities is best positioned for allocation of supporting resources. If it's not, look for other clinical issues. If your question is a current priority, great! Get a few colleagues together and form a mini team. Get the team to start searching for relevant literature individually or in pairs. After retrieving the literature, get together again as a group and start to critique the validity, reliability, strength, weakness, and relevance of the literature that you have found. Once you have done an extensive review of the literature, pause and ask, is the evidence sufficient to recommend a change in practice? If the evidence is insufficient, review of additional literature may be required to help you determine whether a change in practice is recommended. A decision may also be needed as to whether a research study should be done. If the evidence is conclusive and points towards a change in practice, go ahead and start thinking of how to pilot the change. But bear in mind that new knowledge gathered from other literature or a new study can also lead to piloting the change in practice. Once the pilot is completed, evaluate if the change is appropriate for adoption. If it isn't, continue to evaluate quality of care and new knowledge generated. The cycle will then begin again. However, if the pilot outcomes are positive and the change is appropriate for adoption in practice, hospital-wide implementation can now begin. Following implementation, regular monitoring and analyzing of structure, process, and outcomes must be done. At the end of the whole process, don't forget to share your results. Sharing of the process and results will expand our nursing knowledge and encourage others to conduct EBP in their setting.
So the Iowa model is a really cool way that we implement evidence-based practice, and it's really easy to follow, which is why we do it. So an example identified, so Iowa, identifies the steps for translating research into practice. So she talked about identifying a problem, issue or topic in nursing, research and critique related evidence, adaptation of evidence to practice, implementation of evidence-based practice, and evaluation of patient outcomes and care practice. So careful analysis and discussion of research or other forms of evidence in the scenario is going to reveal that given the context, implementation won't be practical, right? So following implementation, results have to be monitored to determine if it's something that's actually going to work. And it's okay that it doesn't work. The point is that you tried. So meta-analysis and generation of knowledge, the strength of the systematic review is its ability to corroborate findings and reach consensus. Systematic reviews show the need for more research by revealing areas where quantitative results may be lacking or minimal. And so for me, that's what's so important. I mean, I get on meta-analyses all the time. The strength of systematic reviews is its ability, bias can also occur with selected studies, so you have to be careful when you're reading it. Or like if you're doing your own review, or you read something called a review of literature, it might not be a systematic review, right? Because review of literature, it's going to be maybe extensive, but not quite exhaustive review of the same knowledge. Meta-analysis is a statistical analysis of a larger collection of analysis results from individual studies. And so a meta-analysis will define a problem followed by protocol generation, establish study eligibility criteria followed by a literature search, identify heterogeneity results of studies, so things that are similar, and standardize data and statistically combine the results. Sensitivity testing to determine if the combined results are the same is required. And that's really hard to do. And you think like, oh my gosh, I can never do it. But you can. And in your master's, you'll eventually perform your own meta-analysis. And, it takes time. You have to learn how to write it and how to analyze data. But it's really helpful because then you become really super smart at researching and how to rate data and how to rate evidence. So some disadvantages we've talked about, they emphasize quantitative studies. There are some newer meta-analysis on qualitative. Analysis is only as good as the studies it's used. So if you're, they do a bunch of like single trials, the evidence isn't going to be that high. So you have to be careful. And then collection, dissemination of these meta-analysis and systematic reviews are available in paper and online through the internet. And sometimes you have to pay for a subscription. Now, obviously, if you are through an education system, you're going to have open access to Cochrane database. That's like the largest meta-analysis. But you can find these quite inexpensively or for free usually, and your librarian can help you find them. Okay, here's a cool thought-provoking question. So 12-hour shifts are problematic for patient and nurse safety, and yet they still use them. And there was a published report which referred to studies as early as 1988 that discussed the negative effects of rotating 12-hour shifts. Workers at 12 hours realize more fatigue than workers at 8 hours. Factors related increased risk of injury, age at 24 hours or less than 4 years nursing experience, working in the SICU, working for more than 8 hours. As a clinician reading these studies, what would your next step be? So would we talk about implementing 8-hour shifts? Would we talk about trying to help with those areas? Would we talk about maybe just focusing on one thing, like less than 4 years of nursing experience? So just some thought-provoking questions on what you could do.